This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the Journal of the American Heart Association, published in 2026, titled Impact of Readmission Hospital Site on Outcomes in Patients with Intracerebral Hemorrhage Undergoing Surgery, a nationwide cohort study.
This is a topic that hits home for anyone covering a busy neurosurgical service. We know that patients with intracerebral hemorrhage, or ICH, who require major neurosurgical procedures are among our most complex cases. The initial surgery is often just the beginning of a very long and precarious road to recovery.
Exactly, Dr. Aris. The abstract points out that these patients are at a particularly high risk for both complications and early readmission. But the real question this paper asks isn't just if they are readmitted, but where they go when that happens. The study evaluates the association between the readmission hospital site, comparing the index hospital to a non-index hospital, and the resulting patient outcomes.
For our residents listening, let's define those terms clearly. The index hospital is where the patient underwent their original major neurosurgical procedure for the ICH. A non-index hospital is any other facility where they might show up in the ER 3 weeks later. Ilara, why is this distinction so critical for ICH patients specifically?
It comes down to the specialized nature of the care. When a patient undergoes surgery for ICH, there is a specific surgical plan, a specific neuro-intensive care trajectory, and an understanding of the patient's baseline neurological exam by the original team. The paper highlights that because these patients undergo major procedures, the management of their postoperative complications is often highly technical.
Right. If I've evacuated a deep-seated basal ganglia bleed or performed a decompressive hemicraniectomy, I know exactly what the intraoperative findings were. If that patient is readmitted to a non-index hospital, that new team might not have access to the operative notes, the immediate post-op scans, or the nuances of that patient's clinical course. This creates what we often call fragmentation of care.
And that's exactly what this nationwide cohort study aims to quantify. By using a nationwide cohort, the authors can look past single-center biases and see how this fragmentation affects outcomes on a massive scale. For our medical students listening, remember that nationwide studies like this provide high statistical power to see if non-index readmission is an independent risk factor for worse outcomes.
Looking at the focus of the study, they are specifically looking at patients who underwent major neurosurgical procedures. We aren't just talking about medical management of a small ICH. We're talking about patients who were sick enough to require the OR. These are patients with high morbidity risks from the start.
The study suggests that the site of readmission, whether they return to us or go to a different facility, significantly impacts their trajectory. While the paper focuses on the association with outcomes, it forces us to think about the systems in place. If a patient is readmitted to a non-index hospital, are they getting the same level of neurosurgical expertise? Does that hospital have a dedicated neuro ICU?
That's a great point. Often, non-index hospitals may be small community centers that aren't equipped to handle the sequelae of a major neurosurgical intervention. If a patient presents with a postoperative infection, a shunt nofunction, or a delayed seizure, the index hospital is naturally better positioned to manage that because they have the institutional memory of that patient's brain.
And the abstract notes that these patients are at high risk for early readmission. This is a critical window. If the complications happen within 30 days of the major surgery, the physiological impact of being at a non-index site could be even more pronounced.
So for the residents and practicing surgeons, what is the takeaway? We need to be aware of the readmission hospital site as a factor in our quality metrics. If we're seeing that patients readmitted to non-index hospitals have worse outcomes, it might mean we need to do a better job of educating our patients and their families on why they should return to the index center if a problem arises.
It also suggests that from a policy level, we need better data sharing between hospitals. If a non-index readmission is unavoidable due to geography, the original surgical team should be integrated into the care as quickly as possible to mitigate the risks associated with that hospital site.
This study really highlights that the surgery doesn't end when the skin is closed. The continuity of care, specifically the site of readmission, is a vital component of the surgical outcome for intracerebral hemorrhage.
It's a call to look at our post-discharge pathways more closely. If you're interested in the full dataset and the specific hazard ratios for mortality and morbidity at non-index sites, I highly recommend reading the full text in the Journal of the American Heart Association.
Excellent summary, Ilara. That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. Keep learning and keep operating.
We'll see you next time.